Good afternoon, ladies and gentlemen. I would like to welcome you all again. Now we are going to have a panel discussion on male lower urinary tract symptoms. And I would like to call the following: Dr. Anant Kumar, Dr. Sarvanan K, Dr. Uttam Meety, and Dr. Nagraj Hess as panelists for the above discussion. And I would like to call Professor Paul Abrahams to be the moderator for this discussion. Thank you.
Good morning, gentlemen. And I look forward to being taught by you. So I like to bring case presentations that I don't know the answer to. So I want to show how limited my knowledge is and how you can help. Is that okay?
Yeah, you want to see the certificate later on. The candidates failed.
So I come from Bristol, and we're very lucky we have a nice new hospital. We've got a nice new hospital in the north side of Bristol. Bristol's quite a small place. It's 500,000 people by Indian standards. That's really a small town, isn't it? I've been coming here a long time, and I'm very happy that to be here again. And I think the first USI event I went to was Varanasi, and you recognise the old friends, and I've still got that jumper. I remember my wife bought me this jumper in Paris, and it was incredibly expensive. My grandfather was a Methodist, and Methodists are very clean living, and they don't spend money. So my wife bought this, and it was really expensive, and she said, it's good quality, it will last. And it's true. Unfortunately, good quality costs money. And I still have this put over, and it's now 15 years ago. So there's a lesson for us all there. Listen to our wives a bit more. So I've got a series of cases that you will find variably interesting. So this is a gentleman who's he's 83. He has a 4-year history of lower urinary tract symptoms, mainly consisting of urgency incontinence and nocturia. He's had urodynamics, and that showed detrusor overactivity incontinence, so that explains his urgency incontinence, and he also has bladder outlet obstruction. His incontinence is quite significant, and during the urodynamics we showed that he started to leak at quite small bladder volumes. So what would you suggest about his management, gentlemen? Do you want any more tests, or?
I like to ask for an ultrasound scan of the abdomen.
You want a scan?
Of the abdomen.
Why?
I want to know what
I'm going to challenge him, okay?
Yeah,
why? Why does he want a scan?
I want to know the bladder wall thickness, the residual urine in the bladder, and any hydrouretronephrosis, upper tract changes are there or not. That is one.
But no, I'm following the guidelines. There's no indication for ultrasound of the abdomen. He's had urodynamics, has a small residual urine. Bladder wall thickness. What would you expect the bladder wall thickness to be in this?
No, why do you go straight
away?
What
Would you expect the bladder wall thickness to be here?
It will be thickened bladder wall.
Well, we know that the bladder wall will be thick because he has a long history of detrusor overactivity. We were talking about this yesterday, and I said to the audience, how many minutes are there in 24 hours? Would you believe nobody knew? And their mental arithmetic skills were very limited, so they couldn't do it in their head. Anyway, there are 1,440 minutes in 24 hours. And then I said, how long do you pass urine for in 24 hours? And I think the young man, well, he was young compared with me, but he was a consultant. He said about a minute, and I said, how often do you go? He didn't know or wouldn't declare. So we agreed that most normal people will go, takes 30 seconds, and they'll go maybe 6 times. So you spend 1,437 minutes filling your bladder, and you spend 3 minutes emptying it. So, does obstruction cause bladder hypertrophy? If you were going to the gym because you wanted to have bigger biceps, you would spend them more than the 3 minutes a day, wouldn't you? A lot more. So I think if you have a history of a man like this with detrusor overactivity, then you will have a thick bladder wall. So I would say, in this instance, I never do ultrasound of the lower urinary tract, and I wouldn't do ultrasound of the upper tract either here, because there's no specific indication.
No,
so I can't give you that
I'm going to
information.
question why the urodynamic evaluation was done as a first modality, which
well,
is an invasive modality. Why not we go for an office diagnosis of an ultrasound scan and the uroflowmetry, then go for the urodynamic evaluation?
Well, I absolutely agree with what you've said now. Now, I wasn't in control of this patient. I saw this patient later on, but I absolutely agree with you. We would, a man like this, we would take a good history and we do a flow rate and an ultrasound to assess residual urine.
Yeah.
But I know his residual urine because he had, but I agree with that, absolutely.
Okay.
So what else would you suggest? Anand?
Yeah, see, this patient needs definitely treatment, so I would like to have more information before do some lifestyle modification and pharmacotherapy. Like I would like to know his uroflow and his PVR and his bladder diary.
Well, we know he's obstructed,
Yeah,
so he's got a
low
flow and a small residual urine.
Yeah, and then because I would like to know what is the water intake, especially from the evening onward, whether I can decrease it, whether he's a diabetic or not, whether he also, like even if I am going to put him on alpha blocker and anticholinergic size of the prostate, if I add dutasteride also. So I need some more information to decide, probably first thing, depending on discussing with the patient, he's 80-year-old, if I can manage him with the lifestyle change, maybe he may require some mini RIN also. All those things I have to see before all those information. If I have, I can plan his treatment. So those information is lacking to me now.
Now, let's say, let's go back. Say, let's pretend for a moment that you had decided he was fed up and he's got bladder outlet obstruction and you recommend a TURP.
He can, like after looking and discussing with, but we will tell him that you will still need a anticholinergic because of your overactive bladder and detrusor overactivity.
Sorry,
you will also need some...
can I get that clear?
Yeah.
You say he would need an anticholinergic. Are you talking about after the TURP?
Yeah,
before?
No, he will start, yes, after the TURP, he will require anticholinergic, which will take some time to act, and he may be better in few weeks to few months time. He won't be better at that. Plus, we also need some other modification to make him better.
No, I agree with you, and I think the issue is this man is over 80, so he has detrusor overactivity. So the chance of the detrusor overactivity going away after TURP is much reduced. So if he was 68, then you would say you have a 2/3 chance that your detrusor overactivity and your overactive bladder symptoms will go away. So our discussion with this man was exactly as you described.
With this information, I would like to start with alpha blocker and anticholinergics. What is wrong in it?
Okay, well, we've done a bit of that, so let me just go on. I haven't given you, of course, I don't give you all the information. That would be too easy for you. So we explained to the patient that because he has detrusor overactivity incontinence and because he's elderly, it's highly likely that even if we did a very good TURP, relieved his obstruction, he would still have detrusor overactivity and detrusor overactivity incontinence. And indeed, some men say their overactivity incontinence is worse after a TURP, maybe because you reduce the outlet resistance a little bit, and it's more difficult for them to hold on. I don't know, I'm guessing. So we explained that to him. He tried solifenazine, he'd switched to fesoterodine, He'd also been on tamsulosin and dutasteride. So he'd had a lot of medication. His symptoms were unchanged by all this, and he'd had anticholinergic side effects and stopped. So we did what you suggested. What would you do next?
If this patient comes to me, I like to change the solifenacin, because solifenacin, the side effects.
Well, we have. We changed from solifenacin
I'm going to stop
to
that.
phenytoin.
I'm going to give a beta-3 agonist.
Okay, good.
Which is well tolerable.
So
in many
we
patients.
switched him to 50 milligrams of mirabegron. We continued with the prostate drugs. You could argue, is there any point in that? And I can't really defend that. We could have stopped the prostate drugs. Anyway, he was happy to continue, and he actually had a very good response. So he had reduced, and I use the word reduced. He didn't lose his urgency, he didn't lose his incontinence. And I think this is a discussion that we have to have with all patients when we treat them for overactive bladder. If you tell the patient, I mean, patients always assume that if you take a tablet, so if you take a blood pressure tablet, you assume your blood pressure becomes normal, because that's what's supposed to happen. If you take an antibiotic, the infection goes away. So patients make an assumption that whenever we give them a treatment, we're curing them. And so I think expectations are really important, particularly with antimuscarinic agents, because we all know that you get side effects, and if you don't tell the patient about the side effect, they get really fed up. So you have to warn them that you may get a dry mouth. You have to say, we don't really know why you have detrusor overactivity. Well, you wouldn't use those words, but you know what I mean. We don't know why you've got an overactive bladder, and your friend who's the same age doesn't have it. Therefore, we don't absolutely know what causes it, and therefore our treatment is less than perfect. But we're sure that we will be able to help you. The behavioral modification is, again, very important. So behavioral modification plus drugs gives you the best conservative response. So I think setting the patient's expectations before everything we do, drugs, operations, whatever we do, is really important. Because if we don't tell patients about possible problems and then they happen, they think we're stupid and they become disillusioned. Particularly true. So he's done actually really well, and we're just watching and waiting. And when he was last seen, he was happy. He didn't want to have prostate surgery, and we were happy not to give it to him. Good. Well, the other wonderful thing about India, you get the culture and you get incredible wildlife. And this was somewhere in the north of India. I've forgotten the name of the reserve. And we were going through the reserve, and we were it was close as gentleman in the blue shirt to this leopard. We went past it, and the guide said, stop, and told the driver to reverse. And he said, look, couldn't see anything. And just 20 meters away, there was this leopard sitting there, perfectly camouflaged. And then, of course, once you see it, it's obvious, but incredible camouflage. So India's fantastic because of the combination of, well, the weather, it's good, plus, of course, the culture and the natural history. So let's talk about this chap. So he's 72. He's got mixed storage, and when we say storage, really, what we mean is overactive bladder, isn't it? That he's probably troubled by urgency, possibly urgent incontinence. Of the patients that come to our department with LUTS, 20% have incontinence. 20%. So it's a bit crazy that the IPSS doesn't have the most bothersome symptom within the questionnaire. So he had mixed storage and voiding symptoms. He'd failed on alpha blockers. His quality of life was affected by his symptoms. He had a prostate which felt benign and approximately. So I agree, we carry on doing DRE, but nobody believes that they're very good at assessing size. And of course, GPs are completely useless at assessing size. And our GPs in England will say, I can't assess prostate size. I was never trained to, and I don't do enough rectal examinations to be any good at it. Now, we do lots of rectal examinations, but we know from studies that we're not that good. 20, 30% inaccurate in size. Nevertheless, we thought this was about 50 grams. His bladder diary showed that he went 8 times during the day and twice at night, and he indicated that he got episodes of urgency every day. What would you like next?
I will discuss with him and probably add 2 more drugs because his size
Sorry?
is 50. I will add 2 more drugs, dutasteride and anticholinergic. Probably start with sulfenacin or mirabrigan, and because he has got urgency, urge incontinence, he's got 50 grams of prostate. By adding these 2 more drugs,
So
we
you
might make him
you
better.
choose an anticholinergic and
Dutasteride.
what?
Dutasteride. Finasteride or dutasteride. 5-alpha reductase
okay.
inhibitor.
Okay. Not an alpha blocker?
Alpha blocker is already an alpha blocker.
No, he
So-
failed. Well, yes, he failed.
So
failed.
I means that he is still taking alpha blocker. So with alpha blocker, I will add dutasteride and anticholinergic.
Yeah, I'm sorry, he's not on the alpha blocker because he said it didn't work.
So I will give alpha blocker, dutasteride, as well as anticholinergic.
And you say dutasteride and not finasteride.
You can use
You
any
don't
one
care.
of them.
Okay,
Dutasteride,
fine.
it is little faster
All right.
acting than.
Okay.
Yeah.
Anybody got anything further to add? Well, we did a flow rate. So we did something right in the initial assessment. And so this is 0 to 25 and the flow rate, so that's 12. So the flow rate's about maximum of 8. What would we tell him about the chances of obstruction? From what Nitin showed us earlier, then the chance is about 70% that he has obstruction. Oh, that's good, but 30% that he doesn't have obstruction. So he did his flow study. At this stage, I just want to bring in the
voided volume for that patient is hardly 100 ml. So that 8 ml of flow is not too bad.
So the voided volume, so that's 600, 300, 150. So it's about 150. So it's not too bad. So I just want to go over with you how we define obstruction. So obstruction, as Professor Nikri said, can only be diagnosed by pressure flow studies, absolutely. And so we do that with a combination of looking at the maximum flow rate, Qmax, and the pressure at maximum flow rate. So if he has a maximum flow rate of, say, 25 and a PDEC Qmax of 90, then we will put a mark here. Okay, so that determines his obstruction. So if you're up here with high pressure and low flow, you're obstructed. If you're down here with high flow and low pressure, you're unobstructed. So that's obstruction. We can also calculate contractility from the same measures. Sorry, what I didn't say was you put it in this equation. So it's PDEC Qmax minus Qmax, and that gives you these figures. If you want to know contractility, then again, same figures, PDEC Qmax and Qmax, but this time it's PDEC Qmax plus 5 Qmax. If you've got a strong bladder, you've got relatively high pressure and relatively high flow. If you've got a weak bladder, as you would expect, you've got low pressure and low flow. So this is his urethral pressure profile. Now, I won't bore you with this too much, but this is measured by putting a catheter into the bladder and then withdrawing it through the prostate, through the sphincter to the outside. So here the pressure is being measured in the bladder. This is now the beginning of the prostate. So the prostate goes from there to there. So this area here is due to the pressure squeezing onto the catheter from the prostate. So the length of the prostate and the height of this plateau, you will see that the pressure here in the prostatic urethra goes to almost 100. And now this is his sphincter. After TURP, then all you would see is this. The pressure would go along like this. If you can do a complete TURP, goes along to this point, and then it looks like a female urethral pressure. So sometimes if we have a patient like the first man who has a very overactive bladder, you try to fill him, and you get to a volume of 50, and then he empties. And you can't get a decent volume that you need to make an assessment of obstruction. So sometimes then we lie them down, sometimes that works, you can fill them better. Or if they've got a prostatic plateau like this, we know that that correlates with obstruction. It's not a great correlation, in the same way that prostate size is a correlation, but not a great correlation. So it's just an adjunct that we use, and we see lots of complicated cases, so in other circumstances that's useful. So here's his filling cystometry. We've got bladder volume increasing there. This is red for rectum, abdominal pressure, blue for bladder, and green is the subtraction. And of course this is detrusor pressure, which equals the bladder pressure minus the rectal pressure. And we talked about quality in the first talk, and that quality is determined by getting the patient to cough or to do a Valsalva maneuver here. That's a strain. You can see a cough is very fast, a Valsalva movement is obviously slower. And if this subtracts out completely, if these are the same on the rectal trace as on the bladder trace, then they subtract out. That's high quality. So whenever we do urodynamics, you look at quality first. If the quality is no good, the urodynamics is no good. So this is a good quality urodynamics, and you can see here that if we look at detrusor pressure, there's a series of waves. They're not particularly high, so that's 0 to 100. They're only up to about 20 centimeters of water, but they gave the patient the desire to void, and they gave the patient urgency. So this reproduces the patient's storage symptoms of urgency. We then got him to void, so this is the voiding phase now. That's signaled on the machine by this shaded area. And of course, obstruction is high pressure and low flow. So his flow is 6, if you can make that out, 6 ml per second is maximum flow, and then we're interested in the pressure at maximum flow, and that is 161. So high pressure and low flow. If we stick him on the nomogram, you can hardly see him on the nomogram. He's up here with very high pressure, and low flow, and so he's well into the obstructed area. So we know he's obstructed. In terms of contractility, as you would expect, he's got this huge bladder contraction. His contractility is excellent, so he has a strong bladder. How do you think this might, we haven't heard from you, how do you think this, if we have this result about his bladder outlet obstruction, how can we talk to the patient about his possible outcome? Will we be positive, negative, or will we guard our comments?
There is increased incidence of incontinence because of the high pressure.
Well, I wasn't going to think about incontinence for a minute. I was thinking about in terms of relieving obstruction and getting him to empty his bladder completely. Are the chances good, do you think?
Yes,
the chances. I agree. So this is the sort of patient we want to operate on. High pressure, low flow. They have good results. But quite right, you're commenting about the detrusor overactivity. The good thing about him is he's younger. So he's 70, I think he was 72. So his chances of reversing his detrusor overactivity are much better than the first man we saw. So I think we could be enthusiastic about his outcome from surgery.
Professor, can I ask you some questions rather than you ask me? So these patients who have detrusor overactivity with urgency incontinence, the patient might ask, what is my probability of getting it reversed? I mean, I'll get benefit not only from the point of obstruction, but of the urgency symptoms. So is there any correlation between the duration of symptoms and reversibility?
Any correlation between?
The duration of symptoms, like
okay, that's a good...
Suffering for 4 years.
Yeah.
So,
well, yeah, there is a little bit, I think. It's not, again, it's not a perfect correlation. The longer the history of detrusor overactivity and the more severe the detrusor overactivity, then the worse the chance of getting rid of it. But it's not a perfect correlation. But I think it's something you have to talk to the patient about. Yeah.
And the next question is, if I need at all that anticholinergics or beta-3 agonist, how long I have to continue?
Well, I mean, obviously, if he has a problem beforehand, then I think a lot of people would try it beforehand to see whether the drugs help, and that's reassuring. That's a bit the same in women, isn't it, with mixed incontinence? It's sensible to try and overactive bladder treatment beforehand, because if they still have the problem after, and it worked before the operation, it probably will work after the operation. So I think that's a very reasonable thing to do. Yeah. So then you could imagine putting the patient onto combination therapy. Good. So management, what next? Well, we've been through that. We've discussed about what we would do. Well, we haven't actually. So would you do a TURP on this man? Or would you treat him medically, more aggressively medically?
Now we have seen that he's severely obstructed, so better we should relieve the obstruction by removing the prostate, whatever way we do it.
Okay. All right. Well, I think one has no problem with defending that.
Why can't we try medical line of management for another 6 months and see the response?
Yeah.
I'm going to give a combination therapy with mirabegron, wait for 6 months, see the response. If he's still not happy, then I go for a surgery.
Yeah.
Why can't we do that?
And if he's happy?
If he's happy, continue that.
Yeah. And this is an important point, because when I trained originally, it was thought dangerous to delay TURP. The terrible things would happen to the patient. They'd all go into renal failure. Now there's no evidence of that. So patients have real choice. If they don't want an operation, then almost always it's fine. You don't have to worry about it. If they've got a residual urine and they've got obstruction, well, I'm going to say to the patient, a significant residual urine, I mean, say, going to the 300 level, I would say, well, I really want to keep an eye on you. Your kidneys look fine at the moment, but I want to do repeated ultrasounds once a year, say. But for the rest of the patients, I think you can be completely relaxed. There's no evidence of significant numbers of patients getting into trouble by conservative management. So as far as I'm concerned, they can carry on with drugs as long as they want.
Can we get some more information? Well, since we have done the urodynamics, if those patients whose end filling pressure is high and they are obstructed, so they will be better, obstruction should be relieved rather than keep them on medical treatment for longer, because they will have a high risk of renal failure.
We'll come on to that. Yeah. Good point. If we don't get to it, remind me to talk about it. Okay, well, this is a man of 68, and he gives a 4-year history of LUTS and says that Nocturia is his most bothersome symptom, and he gets up 5 or 6 times at night. He also has overactive bladder symptoms, but he doesn't complain of slow stream and hesitancy, and we thought he's overweight. We thought his prostate was probably about 30 grams. What other information would you like?
Definitely, I would like to have the bladder diary. Like what is his intake and whether he is producing more urine in the night or not. So whether he has got a diary or not.
Just remind me, do the EAU guidelines mandate a bladder diary? I can't remember the exact wording.
No, they say that this should be a strong recommendation for all patients with storage symptoms.
Right, okay. Strong recommendation. If that was the AUA that said that, that means if you don't do a bladder diary, the patient can sue you. In the EAU, that doesn't mean that. It means what it says. It's a strong recommendation. So I would agree. I would say that if you mistreated somebody like this and you hadn't done a bladder diary, I would stand up in court and say that's negligent. So I agree. Bladder diary. Let's hope the next slide. I'm so confused with all these cases, I can't remember what the next slides are. Ah, thank God it's a bladder diary. Good. Okay. Can you see this clearly? So this is the only validated bladder diary that exists, and it's one of the ICIQ modules. So it's a 3-day diary, and here you see 2 days, day 1 and day 2. Can you see clearly from the back? Well, then you shouldn't sit right back there. Come down here. so it's her own fault. So we've got time from 6 in the morning to 5 at night, 5 in the morning. We've got the amount they drink, water, juice, coffee, I'm translating for you, tea, and then these are the urine volumes, okay? And this is the next day, which we'll see is relevant. So has anybody got a diagnosis from this?
Nocturnal volume is more than the daytime. Nocturnal urine volume is more than the daytime.
Okay, so you'll make a diagnosis of nocturnal polyuria, are you? Well, that's a bit difficult to see, and I'll make it slightly easier for you by doing this, okay? So he in fact got up at 7 o'clock. So these volumes are urine that was produced the previous night. So you don't count those. So these are the volumes, 150, 150, 240, and 200, this is urine he produced during the first day. So that's his daytime urine production. Now, the 330, the 300, and the 340 and the 270 are urine he produced in the night. So they come into the night time. So you have to remember that actually when you're calculating whether they got nocturnal polyuria, you have to look at the night time and then go into the next day. So if you add all that up, I know why the slide is actually compressed, you will notice, those of you who are spatially aware. So it's chopped off the words on the right-hand side in this case. And that shows that I think the volume was something like 750 during the day. We don't know how to do it. It's a technical problem. The daytime volume was 750, the nighttime volume was 1200. So this is nocturnal polyuria. Now, nocturnal polyuria is extremely common. Urologists know more about it than almost anybody else. Most people out there have no idea about nocturnal polyuria. They don't even know it exists. So the reason the EAU says you should do a bladder diary is because 60 to 80% of patients, older patients who go 2 or more times at night, have nocturnal polyuria. Is nocturnal polyuria a urological symptom? Is nocturnal polyuria not a urological symptom? Okay, we've only got 5 votes out of 100. Can I ask the question again? Who thinks that nocturnal polyuria is a urological problem? Who thinks it isn't? What? I'm not asking you. Who thinks it's not a urological problem? Okay, good. Well, it isn't a urological problem, you're quite right. Now, the definition is slightly different. You young people, you're lucky because you have a very efficient urine concentration ability, and you cut your urine down, your urine production down at night. So the young ones, we'd expect 20% of a 24-hour. The older ones of us, well, you know, it's bigger, less than a third. But as we say, 60 to 80% of men and women with nocturia 2 or more times have nocturnal polyuria. So it's very prevalent, as indeed is nocturia. So in the old days, if you were stupid enough to come to a urologist as a man and say you had nocturia, he'd take your prostate out. And of course, because nocturnal polyuria is not a urological problem, it made no difference to your nocturia. And if nocturia was your main complaint, you were a bit fed up about that. We completely ignored nocturia in women because they didn't have a prostate we could remove. Now, if you were daft enough to go to a gynecologist as a woman, they might have offered to take your uterus out because there was an equivalent. If you remember, the older urologists will remember that, you know, the women all got their uteruses removed if they were daft enough to complain about lower urinary tract symptoms. So the gynecologists were as bad as us. But if you look at, these are a number of prevalence surveys, and what you see is with age, you see how much increase there is. So the colour code has been chopped off, not very helpfully. but you can see this is once at night, the red one is once at night, and the green and blue is 2 and 3 times. And you see the pattern is almost the same in men and women. So when a man complains about getting up, if he's 75 and complains that he gets up once at night, you tell him to go away, because 75 is here. 80 to 90% of all men, these are community studies, 80 to 90% of all men get up at least once a night. And surprisingly, even if you go down to a younger age, down to 40, then you can see that something like 1/3 of all men get up at night at the age of 40. So it's very prevalent. How do we treat it? Well, you look, obviously, this is where the bladder diary is vital. You look at the patterns. So there are some people we know who drink a huge amount in the evenings. I mean, lots of English people will go to the pub every night and drink 2 litres of beer every evening. Well, if all of us drank, well, certainly if I drank 2 litres of beer in the evening, I'd be up several times in the night. So, you know, some people don't work out that what goes in here comes out from there. So you have to explain this. The types of fluid, not so important for Nocturia. I think alcohol is important. Caffeine, of course, is very important for overactive bladder. Timing of fluid intake. The other thing that patients don't know is that food contains water. So, for example, we have a lot of women who are constipated. They know about a good quality diet. They eat lots of fruit, vegetables, and salads. But they don't realize that they're 90% water. So they're increasing their fluid intake a lot. So again, I advise patients who are getting up a lot at night to have a rather drier food in the evening and to eat all their good quality food during the day. So this is very important. How much should patients drink? Well, I suggest to them that they can adjust their food and fluid intake to get a urine output of 1,500 mLs. And that's a reasonable amount. And to concentrate their fluid and water-containing food to the earlier part of the day. Now, beyond that, and I think Professor Kumar is very right that we should spend more time talking to the patient about lifestyle interventions, because it's what all of us would do. If we had LUTs, we'd all be doing these lifestyle interventions, but it's unrealistic to expect patients to have our intuition about lower urinary tract function. So lifestyle modification is really important. If they have peripheral edema, then treat that. So how many of the young people here, the older people don't need to, how many of the young people here have been to another continent, like America or somewhere? Would you indicate? Been on a flight for 6 or 8 hours. How many of you have been on a flight for 6 or 8 hours? Okay. And did you travel business class? You didn't. Okay. You're not paying them enough. So did you take your shoes off at the beginning of the flight? And what happened when you got to the other end and you put your shoes back on? Tight? Okay. And they're young. Why were they tight? Because you had peripheral edema, and you're young. So everybody can get peripheral edema. So all our patients over the age of 65 have peripheral edema. But remember, it takes a litre in your legs before it's clinically detectable. So older people are lazy, aren't we? We sit about, don't we? We talk to our friends, drink tea and coffee. We don't walk 10 miles a day, probably. So we develop peripheral edema. So the commonest cause, this is expert opinion, expert as defined by somebody from abroad, okay? This is expert opinion that the commonest cause of nocturnal polyuria is peripheral edema. And I get it. So if I spend the whole day in the office and I don't do any physical work at all, I just sit, I've got some varicose veins. Do you want to see? No. Okay. But I will have a bit of pitting edema. It wouldn't be detected by most people, and I probably will have to get up at night. But if I go and do what I usually do, which is to walk for an hour every day, then I don't have it. So I have it, and I'm pretty fit. We're going to play tennis tonight. So are you going to play? So we're going to play tennis tonight. I'm fit enough to play tennis. So I haven't got cardiac failure. Because, of course, the initial thing is, oh, their patient must have cardiac failure. But I think that's very unusual. So these really simple things make a big difference to patients. So I'm thinking of starting a campaign, a mile a day keeps the doctor away. Now, a mile a day actually here, well, it might be all right at 4 in the morning, but at midday it would be a bit sweaty. So it's easy to say that when you come from England. You can realistically walk. But exercise, I think, is very important. Tea time diuretics work. And Andrea Cannon, who I think you know, she was a SPR, she did a very good study, randomized control study of frusemide against placebo. And that reduced nocturnal polyuria in about 1/3 to 1/2 of patients. Desmopressin, of course, is the other treatment you can use. But remember, desmopressin in over 65-year-olds is not licensed in most of the world because it can cause hyponatremia, fluid retention. So older people need to get rid of this fluid at night, and if you stop them getting rid of the fluid at night, then they get fluid overload. And before we realized this, back in the early 90s, no, in the 80s, we put one patient into hospital with coma. Fortunately, he recovered, but he was on intensive care because his hyponatremia was so severe. So you have to be careful. So I've gone on a bit about this because it's so common and it's not recognized that you will see these patients because everyone assumes that Nocturia must be a urological problem. So they will send the patients to you. So you will have the first opportunity to do something about it. Once you've done the bladder diary, so if they've got this common leg edema, of course, if you think they've got a cardiac problem, send them to a cardiologist. But most of them don't have a significant cardiac problem. Adequate exercise. If they have a sleep in the afternoon, tell them to elevate their legs. If they're watching television, also tell them to elevate their legs. But make it clear to them that putting the feet on the table there, you shouldn't put your feet on the table anyway, but it's not high enough. You need your legs really quite high. And compression stockings, well, in India, who's going to wear compression stockings? It'd be horribly sticky and sweaty. So I think you'd have a lot of trouble convincing your patients to use compression stockings. Okay, did you have any further comments about? I've talked about this case because I've talked about this case because in the old days this patient would have got a TURP.
Yeah, in our practice here in India, what we see is diabetes being the uncontrolled diabetes is one of the commonest cause of nocturia.
Yeah.
Nocturnal polyuria.
Yeah.
Once, and these patients we use the beta-3 agonists. We don't use because desmopressin is expensive. So we don't use it. Very rarely we use it. And especially those who have cardiac problems, we are scared to use that. Electrolyte imbalance is a problem. So we try to use mirabegron and good control of diabetes mellitus.
But of course, mirabegron is not going to help nocturnal polyuria at all.
It will bring down the frequency. Not polyuria. It doesn't bring down it will bring down the frequent urination in the night.
Yeah, but in this case it wouldn't work. But I think your point about diabetes is, I mean, we don't have as much diabetes as you do. And actually in UK, diabetes is really quite well looked after. We have this network of specialist nurses. So if you're diabetic and you go to the GP, you don't see the doctor. You see the diabetic nurse. And they're actually very good in terms of general advice. But of course, if you don't control your diabetes properly, then you're going to have polyuria. And that's a complicating factor. Okay, this gentleman was born in 43, so that makes him, what, 75, 76. And he gives a 7-year history, a long history then of overactive bladder symptoms, but he doesn't wear pads. He has no voiding symptoms. he tried tamsulosin. Well, to say he tried tamsulosin, the GP tried tamsulosin. So this is, of course, another problem that we deal with, that every man who complains of LUTS gets an alpha blocker. Even if he's not complaining of slow stream or hesitancy, he gets an alpha blocker. Even if he says, my only problems are urgency and incontinence, he gets an alpha blocker. He doesn't get an antimuscarinic or mirabegron from the GP. So tamsulosin didn't help. He was put on finasteride, and that didn't help. But interestingly, he mentioned erectile dysfunction. So what would you do for this man? Some other medication, TURP, or something else?
I would like to add PD5 inhibitors along with this alpha blocker.
Okay, well, there's some logic there. He's got ED, so PD5 inhibitors would be a possibility.
We do not have any information about his investigation because he has
You'd like a bit more information.
Long duration of history, 7
Okay.
years. He has failed the medical treatment, so we need to have more information about his investigation.
Okay.
So, yeah.
Well, you can have a bladder diary.
Yes.
So the bladder diary here, again, same configuration. You'll see that he drinks quite a lot. Well, I suppose that's not that much. But he drinks beer at 4 o'clock in the afternoon. Now, that's not common. Any of you drink beer at 4 o'clock in the afternoon? I don't think so. I don't drink beer. Well, maybe on a Sunday at the beach I might, but nowhere else. So he's drinking beer quite early in the day. I don't think we should make personal comments about patients, do you, on the basis of their bladder diary? It's not really fair. Yeah. But you see, quite sensibly, he has adjusted his... Well, he's had all this alcohol, so he actually goes to bed quite early, you'll see. Now, one of the other good things about this bladder diary is it's got this bladder sensation scale. I have to explain that to you. So he's scored 3 all the way down here. 0 is I went to the bathroom because I was going on a long trip and I wanted to make sure my bladder was empty. I didn't need to go to the bathroom. 1 is I felt the need to go to the bathroom in a normal way. 2 is I felt that I need to go to the bathroom and I'm going to get a bit desperate. 3 is I had urgency. And we explain on the chart what urgency is. I had urgency. 4 is I had urgency and I didn't get to the bathroom. I leaked before I got there. So this is showing he's getting repeated urgency, but he doesn't have urgency incontinence. Now, a bit more information, of course. Taking a good history is not in the guidelines because there's no evidence that taking a history makes any difference. No randomized controlled trials of seeing patients. Group 1, you don't take any history, you guess the treatment. Group 2, you take a history. So actually, there's some other very relevant thing. Sleep apnea. Do you see patients with sleep apnea? And sleep apnea is a potent cause of nocturia and nocturnal polyuria. So that complicates things. And he's already on, I always forget what this, continuous positive airway pressure. So that's a mask which blows air into your throat the whole time you're asleep. And it's the best treatment for nocturia. In some patients, the nocturia just stops. And the mechanism, the reason you get nocturia, is because you get nocturnal polyuria. The reason you get nocturnal polyuria is because when you stop breathing, you remember sleep apnea is obstruction here. And because you stop breathing, you're gasping to inhale, so you suck more blood into your right atrium, and your right atrium produces atrial natriuretic peptide, which is a naturally occurring diuretic that we all have. And if we've got too much in our cardiovascular system, we produce that, and that causes a diuresis and corrects the blood volume. So that's the mechanism. He compounds the problem by drinking coffee and alcohol. His prostate feels small. Would you be motivated to do anything more?
No, I would like to have his urodynamics because he has 7 years of history and he failed medical treatment. So I would like to have more information to know urodynamics. I would like to have
Okay.
flow, PVR, and urodynamics.
Okay. We did a free flow rate. The free flow rate was 17 with a normal curve, which is good. Although interestingly, he had a significant residual urine. So you don't really know what that means just from a flow curve. And then we did his pressure flow study. So red for rectum, blue for bladder, and green for detrusor. Is it good quality? Well, I can't see any coughs, I don't think. But this sort of detail here, which is due to movement, talking maybe, is the same in the rectal trace as in the bladder trace and is perfectly subtracted out. So that's another means of assessing quality. So even if the patient can't cough for some reason, or you forget to ask him, this will tell you whether this is good quality. So this is a high quality trace, therefore we can use it for interpretation, and you can see that there are frequent detrusor contractions. This one is very high. We know it's a detrusor contraction because there's an increase in pressure in the bladder and nothing in the rectum. So very high pressure. He then voids, and we recalculated this. So you see his flow rate doesn't look too bad. The shape is reasonable. And here are his results. Detrusor overactivity, loss of compliance. Why have we said that? Well, we've said that because his underlying pressure is rising. So he has an underlying rising pressure as well as the waves of contraction. He has a trabeculated bladder because somebody's looked in his bladder. And on voiding, he has a Qmax of 12 and a recalculated PDEC Qmax of 37, which gives an obstruction index of 13. So he doesn't seem to be obstructed. And he's not complaining of voiding symptoms. So that fits in. So what would you recommend now?
In addition to the alpha blocker, we'll add the beta-3 agonist for him. It should work.
You'd add what?
Alpha blocker and beta-3 agonist.
Beta-3 agonist. Okay, right. Now, I didn't mention, did I, that he had been on finasteride? Did I mention that? Okay. Well, he had been on finasteride, and we told him to stop because he complained of loss of libido. So we tried him on an antimuscarinic and mirabegron. Because we know that caffeine makes overactive bladder worse, we asked him to try stopping. And I think it makes overactive bladder worse in most people. So all my friends who have overactive bladder, I've asked them about it. And all of them say, well, I have 1 coffee a day, and then I'm okay. But if I have 3 or 4 coffees, it makes a difference. It makes a difference to me. And alcohol, I think, probably just from the volume. I don't think it has a chemical effect in the same way that caffeine. If you put caffeine onto a strip of detrusor muscle, it makes it contract. So it has some basic science to go. And we sent him away for a 4-month review. At the review, his frequency had come down from 10 to 6. His Nocturia was down from 3 to once or twice. He now drinks decaffeinated tea as the coffee had made his overactive bladder, but no change in his libido. It has not come back. So he's still not interested in sex. So his wife is happy, I should have said, about the fact that he's not interested in sex anymore, but he in general is happy, and therefore we discharged him. Now, why do I show you this slide? Because I don't play golf, because I'm too young and I play tennis. So when I'm old, I'll play golf. Why do I show this slide? Anyone know? Well, because it's the way in which you decide whether somebody can have a 5-ARI, because as some of you know but are keeping quiet, the volume of a golf ball happens to be, by the Lord's design, exactly the figure that separates, in the EAU guidelines, those men who should be offered a a 5-ARI and those men who should not be offered. So if you have a prostate which is bigger than a golf ball, it's legitimate to offer the man. If it's smaller, it's not legitimate. Now they do in fact say, and have they restated the suggestion that doing a transabdominal ultrasound to assess prostate size is a good idea? Yeah. And I think it is. I think as we go through this little bit of my presentation, I think we might decide it's a good idea. Now, here's the EAU guideline. Dr. Kikri is ahead of me. I didn't realize that 2019 came out on Tuesday or whatever it did. So this is the question that's important. Voiding symptoms predominate. If the prostate's more than 40 grams, you ask the patient, are you prepared to take drugs long term? Now, of course, you don't ask that about alpha blockers because alpha blockers work straight away. But because 5-ARAs take 3 to 6 months, if the patient says, I'd just like to try a drug for a month, and if it doesn't work, then I'm going to ask you whether I could have possibly a TURP, don't prescribe a 5-ARA. It's a waste of time. So this is the algorithm. This is a very sensible, I think, way to look at the management of patients with bigger prostates. The issue, of course, with 5-ARIs is, yes, it lowers the IPSS, you know, modestly. Operations, of course, are much better than drugs for BPO. The increase in Qmax is not particularly impressive, but it does go up a bit, but it takes a fair time to work. And of course, prostate volume, the reason it doesn't disobstruct the patients is because 5-ARIs only work on the epithelial component of the prostate. And unfortunately, on average, the epithelial component is only 30%. So it doesn't work on the stromal component, and that's 70% or more. So that's why you have these rather disappointing falls in prostate volume in the randomized controlled trial. Nevertheless, you can consider offering it to men with prostates greater than 40 grams. But if you look at the adverse events, reduced libido is the one which stands out.
Paul,
you can get erectile dysfunction.
Excuse me, can I interrupt you for a minute?
Shall I just finish?
Yeah, please.
So this is the one that stands out. You can get erectile dysfunction, etc. And you can get, of course, gynecomastia, which troubles patients. But there's a new thing, a new kid on the block, and that is warnings about adverse events of finasteride. Now, interestingly, these have come mainly from people who are taking finasteride for male baldness. And there is now in Europe, in Korea, and in America, a safety warning added to the information the patient receives. There is also an issue around psychiatric problems and an incidence of what they call suicide ideation, which means the patients think about killing themselves. So these are obviously two issues which I think are important. If you go to the internet, there is in fact now an American-based patient group called the post-finasteride syndrome. And some of you know Irving Goldstein, a very prominent American urologist who specializes in andrology, who has made this statement for this group, saying we are becoming more and more aware of persistent sexual health problems occurring as a result of 5-ARIs in a subset of patients. And I've seen 3 patients who've had the drug, they've stopped it, and what they're talking about is the fact that the loss of libido persists, and they never get their sexual function back. But then he says what is even more alarming is that in addition to the persistent sexual issues, there are persistent central cognitive issues and a worry about persistent depression. So I think the message for us is about these drugs is, firstly, does the patient have a prostate more than 40 cc's? Secondly, did you take a sexual history from the man? Now, I asked this in all the meetings, And how many of you always take a sexual history from a man? How many of you don't? Okay, well, you're with me. So most of us don't. But we should, if we're thinking about this. And we must also, therefore, warn patients about loss of libido, and we must warn patients about the possibility that it could cause depression.
How would you use that history? Would you be more willing to give it to the patient who already has erectile dysfunction or not?
Sorry?
I mean, the patient who complains says in the history that he actually is not sexually active. You would be more free to...
Oh, I see. So the question was, what if the patient says they're not sexually active? Yeah, that's fine. I mean, I would document it.
Paul,
that's the only thing I would do.
Can I interrupt you for a minute?
Can I just, I've got one more slide,
Yeah, okay.
and then I'm over to you. So this is the rationale for not using the drug in less than 40 cc. So this is a meta-analysis of 6 RCTs, lots of patients, and what you see here is the IPSS improvement from baseline. So in other words, a reduction in symptoms, and this is the baseline prostate volume going from less than 20 to more than 60. Yellow is finasteride, grey is placebo. So here's trial 1, trial 2, trial 3, trial 4, trial 5, trial. So what you see here is no separation between placebo and finasteride until you get to 40 to prostates more than 40 cc's, when you see a separation. So this is the basis of the recommendation that you shouldn't treat the patient with finasteride unless they have a bigger gland. Sorry, I interrupted you twice.
No, it's okay.
But if I don't interrupt you, I can't remember what I was going to say. You know the thing. Yeah.
Now, what I want to know is, a patient with larger prostate, more than 40 or 50 grams, you have started him on dutasteride or finasteride. How long do you continue that? Do you think that when the prostate size stops, it must be stopped? Or can the patient continue on that, if she has got benefit of it, barring libido and whatever other things that you have? Like what Sanjay said, if it is not sexually active, it may not really matter to him at all. So if those patients, can you continue on finasteride if it's benefiting him as far as passing urine is concerned? Or since the size has come down, there is no other purpose because there is no epithelial tissues available in the prostate.
Yeah. Well, I think that's a very good question. So should we be telling patients they're on finasteride for life, or can we say something different? Now, the realistic situation is that nobody's ever going to do the trial. The drug company won't do the trial because the drug company want the patient to stay on it for the rest of their lives. But I think what you say is correct, what you imply is correct. So once you've shrunk the prostate, which takes 6 to 12 months, why the hell do you need to carry on at the same dosage, for example? Maybe you could take 1 or 2 tablets a week, or maybe you could stop and see what happens. So this hasn't been done, and I see no reason why you shouldn't do it. And certainly if anybody has sexual dysfunction, I would be stopping the drug and seeing what happens. But as far as I'm aware, there's no information. Do you have some information?
No, what I'm thinking, like, unless if you stop the drug, the prostate is going to grow, isn't it?
Well, we assume that it's going to grow, but remember the patient is older. So if the patient's been on the drug for 5 years, and you've shrunk the prostate as much as you're going to shrunk, you don't know, because he's 5 years older, it may take him much longer to regrow the epithelial component. And we don't know how long it takes to regrow it. We know it takes 6 to 12 months to shrink it. Maybe it takes 10 years to regrow it. Who knows?
But I have read papers, I don't remember, and it has been in those papers recommendation that you can give 5-alpha reductase for 6 to 12 months, then take it off, continue with the alpha blocker, and most of the patients do well for a long time.
That's reverse. No, the paper is reverse. What has been tried?
What they have tried is give alpha blocker and finasteride or dutasteride. Stop alpha blocker after a period of time and then continue on.
I remember paper, but I don't remember.
No. I can tell you the papers always has been. The genesis of all this is actually, if you go back to the Veteran Administration trial, which was done first initially for 1 year of a combination therapy, which failed to show any result. So that gave the hint to the company that they need to try longer duration of finasteride. And that's why the longer duration came in, and the longer the duration they could show more effect. But another point which I want to make, which was in connection with India, and especially developing countries, where the treatment is borne by the patient. The patient has to pay for the treatment.
Yeah.
It is so important not to get carried away by the medical treatment in a patient who is genuinely obstructed. The reason why I am saying so is, number one, the benefit is minimum, the cost is huge, and the long-term cost of using a combination therapy outweighs the cost of a surgical intervention in a big way. So I think this kind of a thing, that's continue patient, especially whom you have urodynamically diagnosed and proven to be obstructed, it's to be very, very careful done in our scenario, because the cost is huge, the implications are not easy, plus the side effects. We completely ignore, in general in our country, the side effect profile. We assume that patient is not interested. There are a lot of people who come back and then quietly they'll ask the wife to go away, or their son is coming with them, they say, can you, and then he will say, after starting the medication, these things are happening to me and I'm not happy with it. So it's not that these drugs are without side effects. Alpha blockers also have a lot of other issues. So I think in our country, the patients who actually are candidate for surgery should not be unnecessarily put on medical therapy. There is a problem with that.
I think the other thing we haven't talked about is residual urine, and bringing residual urine into the equation with medical treatment. So if I see a patient who's obstructed, who has troublesome symptoms, who I would normally treat medically first, but he has a residual of 300, I know that whatever treatment I give him, alpha blocker, 5 ARIs, it won't get rid of his residual urine. And the best way to improve his frequency and his nocturia will be to take his prostate out so that he can empty his bladder completely. Does that come into your thoughts when you see a patient?
Yeah, that's what exactly I was going to ask you. Like, I will give you a situation. Sometimes there are patients whose bladder outlet index is around between 35-40. They are borderline obstructed. They also have a significant overactive symptoms and post-void residue. So in that, and some of the patients are diabetic also. So there is some degree of autonomic neuropathy also. So in this situation, what is your opinion? Like, I feel strongly, if we remove their prostate, we warn them, if we remove their prostate, decrease their outlet resistance, and then give him anticholinergic, they may not go into their PVR may not increase, or rather it may decrease, and they may become symptomatically better.
Well, I think that's perfectly reasonable. And I think the issue of cost, of course, I don't tend to think about that, because all these patients in England will get free medicine because they're all over, most of them are over 65. You only pay for drugs if you're under 65, and then you only pay a set amount. You don't pay by the value of the drug, for example. So it is a difference. And that's, as you said, somebody, was it you talking about NICE? Was it you, Sanjay? NICE is the only guidelines that do a cost-effective analysis. So you're really talking about, for the patient, what's cost-effective for the patient, aren't you? And that's obviously a very important consideration. Bearing in mind, of course, that TURP is the best treatment for LUTS if the patient is obstructed.
So regarding your one comment that if the patient is not interested for continuation of medication, like patient wants, okay, I'll try for 1 month, and then if it doesn't work, I'll go ahead with a TURP, and his prostate is more than 40 cc. In that situation also, you said there's no point giving combination therapy. But one theoretical advantage of combination therapy in such scenario is that if you use 5 ARI, they are supposed to reduce the microvessel density.
Yeah.
So the bleeding component during TURP may be less. So in such situation also, when the patient is deciding for surgery, we can go ahead with combination therapy rather than only alpha blocker.
Yeah, I know. Yes, no, that's a good point to remind us that finasteride reduces the vascularity of the prostate, but presumably you need to keep them on it for at least 3 months. A month, you know, Because it takes 3 to 6 months to shrink
So
the
there are
epithelium.
two things. One is reduction of the size of the prostate, and second thing is reduction in the microvessel density. For microvessel density, the studies are there. It takes about only 1 month or so. So,
But it also depends on the proportion of epithelial to stromal tissue for the individual patient, doesn't it, as well?
Yeah,
So there are a number of factors.
There is one
So I agree, it's another consideration.
There's one RCT which compared the blood loss. It is technical blood loss. Transfusion rates don't differ. So in fact, they concluded that when you try the number needed to treat, it's not cost effective for the purpose of reducing blood supply during TURP. So it's not recommended because of that. Because theoretically, you will reduce the it's like lasers. When you do laser prostatectomy, you clear sodium levels. But does it cause a symptomatic hyponatremia which requires treatment? So it doesn't require. So similarly, am I going to change my transfusion rate because I put the patient on finasteride? The answer is no. So it doesn't actually make a difference.
I think it just shows the value of an RCT, doesn't it, there? Because the observational studies would indicate exactly what you said.
One of the observations that I have made in patients who are on dutasteride and duodenal resection, resection has become far more difficult to do because the planes are not very clear when the patient is exhibited on dutasteride.
Yeah.
Just wanted to make a comment regarding what Dr. Anant asked, because this is a very common scenario where patients who've got an element of underactivity, what he described, and large residuals, and you're thinking about doing a surgery. And I think the way the patient has presented is very important. If the patient does not have a complaint of voiding difficulty in the presentation with all the same parameters that you said, I would be hesitant to operate that patient. But the patient who actually complains of avoiding difficulty with exactly the same parameters is probably likely to do well if you counsel and operate.
Okay, I think I prepared some slides just to sort of sum up. Where's my man? Actually, are you here? He's hiding. Okay, I think I can probably do this myself. Okay, Professor Chawla asked me to sort of sum up at the end, and I think I'm going to bring out some of the points you made about guidelines, and Professor Kumar has already said about the importance of a holistic approach. So holistic is a spiritual, philosophical thing, isn't it, in many respects? But in medicine, it means treating the patient as a whole person, not just as a prostate or as a bladder. And I think in LUTS, it's really important. So the dictionary definition is characterized by the belief that the parts of something, that's us, the parts of the human body, are intimately interconnected and explicable only by reference to the whole, in other words, the whole person. And so much of what we deal with in functional urology has major psychological components. So I think it's something which I always try to remember, particularly if I'm trying to treat a patient and things are not going well, and I don't really understand why things aren't going well, then I try to think, are there psychological issues which are important here? Now, we're talking about male LUTS. Men are, of course, perfectly sane creatures, and we don't have psychological issues, do we, gentlemen? You do? Oh, okay. So some of us do have some psychological issues. So we need to look at the patient in a sort of 360-degree appraisal. Daytime, nighttime, inside, outside, whatever you like to think about. So we've moved, haven't we, from terminology, and it's now 25 years since I wrote this paper suggesting that we use the term LUTS rather than prostatism. Because up to that point, as I said, if you were daft enough to complain of any lower urinary tract symptoms, you got your prostate taken out with, well, basically then, when I started in urology as a very young doctor, you got your prostate taken out on the basis of a history, a rectal examination, an IVP, everybody had an IVP, and a cystoscopy. So we have changed a great deal for the better. In that paper, I also said that, and you brought this out, Nitin, about the definitions of terms. I also said we need to be more careful about the way we use the terms BPH, BPE, and BPO. So the dictionary says BPH is a histological term. Okay? And a histological phenomenon does not stop you passing urine well. And of course, some patients with histological BPH move towards having benign prostatic obstruction. My own personal record is 124 cc's. So this man came with a prostate measured at 124 cc's with normal flow and normal voiding pressure. And all the experienced urologists know here that you can have tiny prostates with terrible obstruction and you can have big prostates with no obstruction. So BPE also usually means the patient can pass urine perfectly satisfactory. So as urologists, we're interested in treating BPO so that the bladder is beginning to look a bit uncomfortable because it's having to work hard to produce what is a reducing flow. And the guidelines have reflected this change in attitude. So in 2001, they were guidelines on BPH. They are now guidelines on the management of LUTS, including BPO. And of course, the real reason why using the term BPH is illogical comes from this histological work. So this is the percentage of men with histological evidence of BPH, 1,000 men. These are the ages, and this is the percentage that have histological BPH. So you will see that by the time you get to 70, you have an 80% chance of having histological BPH. So if one of you young doctors comes into me and say, Prof, I've got a man with BPH in the clinic, I don't laugh at them, I try to be kind. And I say, well, what do you mean by that? What you're telling me is that he's got a prostate. Well, that's good. I think all men should try to keep their prostate. Have you done a biopsy? And they look at me thinking, he's strange. People usually look at me and think he's a bit strange. And then I explain, BPH is a histological diagnosis. You're not telling me anything. This man is 75, he has an 80% chance of having histological BPH. How does that help me in the way I'm going to suggest you manage this patient? If, on the other hand, you come to me and you say, I've got a man with BPE, Prof, then I make the assumption that you've done a rectal examination or for some reason or other you know his transrectal ultrasound or abdominal ultrasound estimate of size. But still, that doesn't tell me how to treat the patient. So what I want to know is, do you think this man has BPO and what's your evidence for that? So using the term BPH, this slide is the most important, showing it's illogical to talk about BPH men. And if you look at the literature, there are tens of papers talking about BPH men, and they all have a different definition. Clinical BPH, that's another common phrase in the literature. What the hell does clinical BPH mean? I have no idea. So give up these terms and just talk about LUTS, suspected BPO. Well, you can talk about BPH because you can measure that, suspected BPO, until you've done some tests. So I agree that the EAU guidelines are really, with NICE, are the standard of care, deliver best practice. And the important thing is, of course, that they do recognize, and this, you showed this very briefly, they do recognize that LUTS has many, many causes. In men, of course, prostatic obstruction is unique, but you will see all the other causes are unisex. So the women have most of the same causes for LUTS as the men do. The other important thing that we know from community studies, and this is a very large community study called the EpiLUTS study of 14,000 men over the age of 40. These are not patients. These are men living in their own homes. who have not complained, and 71% have at least one lower urinary tract symptom. In other words, only 30% have no lower urinary tract symptoms. So lower urinary tract symptoms are endemic. What it also shows us is that symptoms come mixed. So the commonest group of symptoms are the storage symptoms: frequency, nocturia, urgency, incontinence. And you will see also that a minimum number of people have a single group of symptoms. So 12% have voiding symptoms only, 9% have storage symptoms only, and 3% have post-micturition symptoms only, like post-micturition dribble or feeling of incomplete emptying. So most of the men that we see have a combination of storage, voiding, post-micturition symptoms. And therefore we must assume that we are treating men with more than one cause for their LUTs. And the thing I like about the EAU guidelines, and I would remind you that they stole this idea from us who wrote the original guidelines for the ICUD, and that is to ask three questions. Are the man's symptoms predominantly nocturia? In other words, what bothers the man most? Is it nocturia? Is it overactive bladder? Or is it voiding symptoms? And then once you've done that, then it generates these different treatment categories. So I think that's an enormous addition to the way we think about lower urinary tract symptoms. Nocturia I've mentioned to you, and the importance of bladder diaries, again, Professor Kikri has mentioned, and the assessment as to whether the patient has nocturnal polyuria. Now, what about urodynamics? Because here we get into difficulty with the guidelines. I believe in the a priori way of looking at things. So you think about things conceptually. So you've got a bladder, you've got a tube coming out of the bladder's a pump, there's a valve in the tube, the sphincter. Think if you were a hydraulic engineer and the flow from your reservoir, the bladder, was poor. What would you do? You'd test both the function of the bladder and the function of the tube. So the a priori argument is that urodynamics, which is the only way we have of doing these tests, must be a good idea. From the theoretic, that's the a priori argument. So what does the EAU say about it? Well, they say that pressure flow studies are the basis for the diagnosis of obstruction. Okay, well that agrees with my a priori argument, and define obstruction as high pressure, low flow. And then they make the statement that BPO has to be differentiated, They don't say it might be a good idea if you feel like it and you've got time to differentiate between detrusor underactivity and obstruction. But then the summary of the evidence gives a level of evidence of 3 because there are no randomized controlled trials. If we look at it in more detail, then here is the strength rating of the recommendations. All of these are weak. Well, perform pressure flow studies only in individual patients with specific indications prior to invasive treatment, or when you want to evaluate the underlying pathophysiology. Well, why is that a weak recommendation? Those are very specific points. The only way in which you can investigate is by urodynamics. Perform pressure flow studies on people who've had previously unsuccessful invasive, in other words, a previous TURP. Well, I would say that you should be certified mentally ill if you're prepared to do a second TURP on a man without urodynamics. So why is that a weak recommendation? Because there are no randomized controlled trials. Perform pressure flow studies in men considering invasive treatment who cannot void 150 ml. In other words, you haven't got good flow rate data. to back up your claim that the man is obstructed. Weak. Perform pressure flow studies in men with bothersome symptoms, predominantly voiding symptoms, when the flow rate is higher. Of course, if the flow rate's higher, there's much less chance they're obstructed. So why wouldn't you do it? Would anybody here be prepared to have a TURP if they had a flow rate of 15 and were emptying their bladder? I doubt you'd be prepared to have a TURP without evidence of obstruction. Perform pressure flow studies when there's a large residual urine. Well, we already know that a large residual urine can equally be due to detrusor underactivity as to obstruction. And they've already said pressure flow studies are necessary to distinguish between the two. So again, why is that a weak recommendation? Perform pressure flow studies when considering invasive treatment in men with bothersome, predominantly voiding symptoms aged over 80. Well, again, there's very little data. There's one very good paper by Mardesparker showing paradoxically that actually the incidence of obstruction in men over 80 is lower. Now, that's probably because these men over 80 are coming because they've got overactive bladder. As you know, the prevalence of overactive bladder in the community rises very fast with age. So most men over 80 have overactive bladder. So that's a very good idea, but again, it's only attracting a weak recommendation. And here we've got men under 50, and it's only a weak recommendation that you should do urodynamics. Well, again, the chances are a man under 50's symptoms are not due to prostatic obstruction. They might be due to some other obstruction, of course, but not likely to be due to the prostate.
Prof, for the patients...
Now, if we look...
When they give...
Let me finish first. So, let's look at the AUA guidelines. Now, the AUA is a very interesting organization. And, well, maybe I'll say that at the end. So, this is from the guidelines just produced. BPH is a histological diagnosis that refers to the proliferation of smooth muscle and epithelial cells. It's a histological diagnosis. Good. BPH, or histological hyperplasia, in itself does not require treatment and is not the target of therapeutic intervention. Okay? It's really interesting then that they call it guidelines on BPH. Huh? BPH does, however, in many men lead to an enlargement of the prostate. BPE. Not all men with BPH will develop BPE. We agree with that. The prostate gland may eventually cause obstruction, BPO. Not all men with BPE will get BPO. Good, we agree with that. So they recognize that size isn't everything, and that obstruction may also be caused by other conditions. BPH is a histological diagnosis. Good. BPH is not the target of therapeutic intervention. BPH might go to BPE. Not all men with BPH go to BPE. I don't know if you can read that, but again, I'm saying, why on earth do you call these the guidelines for BPH, as they're not the focus of our intervention? So I would say in conclusion, are pressure flow studies needed prior to surgery? Yes, for most men with bothersome LUTs. So as you quoted, Nitin, that even if your flow rate is low, and nobody would disagree that a flow rate of less than 10 is low, but even if it's less than 10, there's only 70% chance that the man has obstruction. So why does he have a low flow? Because, of course, it's due to a weak bladder. So flow and post-void residual measurements do not tell you whether the man is obstructed or whether the low flow and PVR are due to a detrusor underactivity. If the flow rate is greater than 10, there should be a full discussion with the patient about the benefits of doing pressure flow studies. So without pressure flow studies, my question to you is, are you giving fully informed consent? I think all urologists need to understand urodynamics, and I would judge that urologists without the facilities for urodynamics shouldn't be doing TURPs for symptoms. I don't think that's what we would wish our relatives, our fathers, our brothers, our children, or whatever. I don't think we would wish that they had a TURP based on a 70%, and that's the best. Remember, 70% positive prediction is the best that you will get without urodynamics, and only if your flow rate's less than 10. If your flow rate's over 10, then of course the proportion who are obstructed goes further down from 70%. So, thank you very much. I interrupted you, Sanjay. What were you going to ask?
I was going to ask you about the way in which these guidelines are developed. Now, although I was going to ask you about the way in which the guideline recommendations are formulated.
Yep.
Now, with lack of evidence for history and physical examination, the same set of experts are willing to give a strong recommendation.
Yeah.
But with lack of evidence regarding, say, a re-TURP, they still give a weak recommendation for the urodynamics. So the lack of evidence does not necessarily mean that they're not willing to give a strong recommendation.
No.
So then why the weak recommendation for a re-TUR, for instance?
And Nitin said, absence of evidence is not evidence of absence. Did I get that round the right way? Yeah. So just because there isn't evidence doesn't mean that we're wrong. But of course, we cannot be confident. And we know that lots of bad things are done in medicine without evidence because we believe we're right. So still, the randomized controlled trial is the God and should be the God of evidence. It should dictate most of what we do. But until we have proper randomized controlled trials, we should do what is logical, which is why I went back to talk about the a priori argument. It's obvious. If you were a hydraulic engineer, you would check the pump and you would check the valve. You wouldn't just replace the whole system. You wouldn't cut away or replace the valve if it turned out, or if you did, and it turned out that the pump was the problem, then your client would probably be unimpressed by the fact that you had charged a lot of money for replacing the valve when what you should have done was to replace the pump. So it's exactly the same, I think.
I think what your question is, because I did mention those points in the recommendation guidelines, what they do, is not only the question of evidence. The evidence is one part of it. The second is the impact it will have on society and of the recommendation. So for example, doing a DRE, the impact, harmful impact of that thing is very low. So the concern always remains when there is a lack of evidence to support a test which costs money, which costs time. So that is the problem. So that is where their recommendations go weak. Not necessarily they don't agree with it, but because they do not have that support, and because it's an expensive investigation, required a lot of infrastructure, and that will have an impact. So that's why there is a more defensive way of doing it. Not necessarily they don't agree with it, but that it is not only one aspect. Evidence is one, but they also need to know, for example, a urine microscopy, the same thing, the evidence is poor, but because it takes very little, that they know that this is the investment required to do a urine dipstick is far lesser than urodynamics. So that is one of the reasons why these recommendations fall like that.
I think that's
precisely the agreement for having a guideline specific to India, because the availability of investigations, the availability or cost of a particular procedure may be completely different. You may be easily able to do creatinine or an ultrasound scan here, may be very cheap, which may be very expensive abroad.
Not only that, we need to have guidelines, but we need to have a process for making a guideline.
Oh yes, the process is the same. Process is the same. Process is the same.
Not survey-based guidelines.
I think the cruel thing that I was going to say, that I stopped myself from saying earlier, was that you have to think about who is writing the guidelines and why they're writing the guidelines. And of course, under Trump, America is a pure capitalist society. Freedom is very important, and trade unions are really bad. Really, really bad. I can't say that enough. You know how he repeats himself. Really, really bad, okay? Now, the problem is the AUA is a trade union. Now, if I said that in America, they'd kill me, yes, because trade unions equals communism. We all know that, don't we? Definitely. Actually, come to think of it, they didn't used to have trade unions in Russia under communism, because they didn't need them. But anyway, the AUA is a trade union. So what's your definition of a trade union? A trade union is somebody who looks after the members. All right, so we've all seen in your country, I'm sure, and in our country, where trade unions have resisted modernization. Because if modernization means a fall in 10% of the workforce, the trade union will object to it, whether or not it's a good idea. Okay, so let's look at this in terms of the guidelines. The prime role of the AUA is to look after its members. The prime role of the AUA is not to look after patients. So the worst case scenario for the AUA is they write a guideline which says you should do this, and then a urologist doesn't do that, then he will be sued, definitely, 100%, because they will look, the first thing the lawyer will do is the lawyer will look at the AUA guidelines to see what it says. So if you read the AUA guidelines, as Nitin and I have done, they say you may do this. So, for example, in assessing patients, you may do a cystoscopy. Well, okay. Well, you probably won't do any harm, but we all know that it's a complete waste of time. So they are allowing lots of things. Now, the EAUs from the opposite, they're not being strong enough in their guidelines, we think. The EAU are being too weak, much too weak. So this is why there are these silly contradictions, like they say BPH is a histological diagnosis, BPH is not the focus for intervention, yet they call the guidelines BPH. Why the hell do they do that? So they never stop them, they never stop the doctors from doing anything, even when there's good, maybe not RCT evidence, but when there's a lot of good evidence you shouldn't do something, or that it's a waste of time, maybe it's not dangerous, just a waste of time, they will not say that. So stick with the EAU guidelines. If you want to know about cost effectiveness, then the NICE guidelines are very good. The problem with the NICE guidelines is they're not updated very often because it's an extremely expensive process. It's more expensive than the EAU. But the best ones that we have really, I think, are the EAU ones. So I think one needs to interpret these things.
One question which I would like to, I mean, it's not related to the guidelines and what you said, but what you mentioned is that there is a question mark on the prescription of 5 ARIs, mainly because of the new changes which have brought in the mood changes and the actual tendency of suicide, which a patient may have. Now, that is quite a serious issue. Should we be writing them at all? Should we be prescribing 5-alpha reductase inhibitor at all if you are having the mood changes which can include a patient sort of killing himself? If it comes on the advisory of the drug, and if your patient is on that and he actually commits suicide, a doctor can be then, you know, he can be sued on the court.
I mean, I think it's reasonable to prescribe it, but it wouldn't be reasonable to prescribe it without talking to the patient about it. And in the UK context, I would say that all doctors now who prescribe a 5-ARI should document the patient's sexual history. Is the patient sexually active or not? And should ask, does it matter to you if you lose your desire for sex? Is this going to cause a problem between you and your wife? And then the second thing is you should warn them that there is some evidence that you can get mood changes, perhaps depression, perhaps you think about, you're so depressed that you might think about killing yourself. I think you have to say that. And if they say, well, that's fine, I still want to take the drug, then I think you can prescribe the drug. But I think we need to be more careful than we've been previously.
So has your counseling changed after this has come as a
Well, I've never been frankly, I've never been terribly keen on 5-ARIs.
Okay.
I mean, you see this, obviously the group of men are vulnerable, their sexual function is vulnerable anyway because they're older. So it doesn't take much to mess up an older man's sexual function. So alpha blockers, of course, mess it up a bit in that you get reflux ejaculation with tamsulosin particularly, but if you explain that, they don't seem to worry about that. And the other factor is, of course, because it takes a long time to work, it therefore means probably it will take a long time for side effects to go away, I assume. So, yes, I'm responsible for prescribing less than before.
What?
So you had a very small percent of patients, 3%, with isolated post-micturition dribbling.
Yeah.
Occasionally a youngster comes to me with this complaint. No other complaints, no background problems, but a few drops of urine after completion of normal urinating. So that disturbs him, especially when he goes for prayers and all. So how should we go about? Should we have all algorithms?
How do you go about?
Such a complaint. No, there is no residual urine, there is no...
With post-micturition dribble you're talking about?
Yeah, post-micturition dribble.
And we see young men with post-micturition dribble.
Yes.
And you will know very well what type of men they are. They're young Muslim men.
Yes.
Because, of course, you're unclean if you try to go to the mosque and pray and you've got post-micturition dribble. You're expected to go home, wash, change your clothes. So it's extremely disruptive. And the irony is that when I go to the Middle East to lecture, people ask me how to treat post-micturition dribble. And I say, look, you guys see far more of this than I do. Not that it's no more common, of course, but English people wouldn't, people who are Church of England or whatever, they don't care about, well, they might care about it, but it doesn't have the same serious problem for them in a religious or social sense as it does. So, I mean, our treatment for it is pelvic floor exercises and teaching them how to manually express the bulbous urethra. And for most people, that works. But I've certainly seen young Muslim men who are really, really upset about it because it's a big social and religious problem. Anybody here know how to treat it other than by pelvic floor exercises?
I know.
You do?
Yeah, I know.
Have you written it? You should write it in a paper.
I think I'm Muslim myself, and I have learned from the priesthood, not directly, but their explanation is that if the dampness on the clothes is of the size of a dinar is an old coin which is actually pretty large. As long as it is within that size, the cleanliness is not disrupted. So if the size is, which comes to about 2 inch diameter. Okay. So if you assure them that this is what has been prescribed and they are clean, most of them are satisfied. That's one. And two, you need to explain them that this is not a disease, it's a religious entity. It's a religious disease. It's not a physical disease. It doesn't really hurt you in any manner. If you're, as you said, if you're a Christian or a Hindu or whatever, it won't really bother you, you won't even mention it. So once they realize that this is all a conceptual thing, rather than actually an entity which is going to do anything to them, I think that most of them are, they accept it as a fact, that they can't do anything about it.
Sorry to interrupt actually. There's a request from the organizers that we're going to have some inaugural ceremony.
Okay.
So we had a nice discussion. Maybe, I don't know whether it has been included in the program. Other scenarios like LUTS BPO with bladder diverticulum, LUTS BPO with bladder stone.
There's lots we could talk about.
But because of a lack of time and the request from the organizers,
yeah.
we should wrap it up now.
Of course.
Thanks.